So what I wanted to do is again, just talk about the things that I just told you guys I would talk about. When is it maybe the right time to think about it? Now, as I go through this, a lot of the part of intestinal failure surgery that drives the field forward is in pediatrics. And so the data that I'll present a lot of the times is pediatric stuff, but the principles apply to peds and adults, and I do both. That's why I'm in scrubs. I was literally just operating on a short bowel patient before I came here. So so what I'll do is, so don't feel like if I'm talking pediatrics and you're an adult patient or an adult provider, this has no relation to you, because it doesn't. It's all applicable. Okay, so just some simple disclosures. I'm involved in most of the major clinical trials in the field. So I'm working in all of the different growth factor trials in Zealand, Effective Bio, and Takeda, and all that kind of stuff. And that's not gonna be something I'll talk about specifically in this talk, except to say that all the things that happen in the field in toto impact on how we make decisions about surgery. And so the decisions that we would have made surgically about people 20 years ago are very different from the decisions that we would make 10 years ago, 5 years ago, or today, because the field has changed a lot in that period of time. And it literally has an impact on whether or not you should choose surgery. And we'll get into that. So I told you this was going to be philosophy, and that's really what it's going to be. And here's my overriding philosophical principle if you're an intestinal failure patient. And that is to say, if you're not going forward, then maybe you're going backward. And what do I mean by that? Well, I mean, I'm not trying to be facetious, but I'm making the point of saying you should be in the short bowel world. I think our goal should be to try to get people onto, where possible, the least amount of TPN that they can. Now, there are some conditions, many conditions, where that's not a realistic goal. And then what we're really trying to do is minimize how much we're doing and maximize quality of life, and just get you to be able to do every single thing that you want to do in life while you're on your TPN. I often tell people, like, TPN does not define you. It doesn't, your disease does not make you who you are. It's just a part of you. And it's something it's like the color of your hair or the color of your eyes. It's a part of who you are, but it doesn't make you who you are. You're not just that thing. And it's something that we can improve. So my point here is to say, I think in the short bowel world, we should be trying to make progress. And if we're not making progress in advancing on eating, if we're not making progress in cutting down on TPN, then I think we have to sit back as a patient, as a family, as a provider team, and go, okay, what's going on? Like, why are we not making progress? So I think this was a figure that I put together for a book chapter. And you don't need to worry about the whole figure, because my point from this first slide is just to point out one of the things that I think is very important up front. So if something happens, you lose absorptive surface. So this is either necrotizing enterocolitis or complications of a surgery or a blood clot or something. You lose a bunch of short bowel, of small bowel, maybe some colon. And so it leaves you perhaps with short bowel syndrome. And I very loosely say that 50% of absorptive surface. That's not an accepted definition by any stretch, but I think where patients are losing a significant amount of bowel early on, they need to be thinking about being transferred to a transferred to a specialized rehab center. Why? I mean, I think if you lose minor amounts of bowel, that can be managed in a lot of different places. But if you have a patient who you think is going to be going out on parenteral nutrition, or they get out and they're not thriving on parenteral nutrition, I really think that these are the kinds of patients that we should be steering towards the more specialized centers, because I just think it's improving outcomes, it's improving quality of life, and it's allowing patients to access different kinds of things they might not be able to get to otherwise. So what is one of the surgical principles that I believe in? It's something that we preach all the time here in Nebraska. We believe in early restoration of continuity. So what that is to say is every bit of bowel that you have on the inside that's usable, we should be using in almost every circumstance. And I'll make a few caveats to this, but in general, we want to try to get that bowel back working as soon as we can. And so I'm a believer in doing this as soon as you think it's surgically safe. Now, I'll toot my own horn and say this is all I do. I mean, I'm a transplant surgeon by training, and I do transplants, but that's really just one small element of my practice. My practice is just doing complex surgery on intestinal failure patients. And so you sort of get used to it. And so I may be a little more aggressive in the sense of I'm saying, okay, look, as soon as I think we can get in there and restore your bowel and get you back together again, I want to do that. And so sometimes people, will be told, you can never be operated on again. If you're operated on again, you will die. It's the worst thing I've ever seen in the world. Nobody can ever fix you. All you can do is be on TPN. I just don't believe that to be the case. And they may be very correct in saying that to you, because it may be that person shouldn't operate on you anymore. And that's why I think you get transferred into places where we have a limited number of surgeons doing a large number of cases. In that case, we get continuity restored 6, 8 weeks, 12 weeks. We want to be in there putting bowel back together as soon as we can. I think we want to try to use all the bowel that we can on the inside, but we want to use it if it's good. Not all bowel is necessarily quality bowel. And in some cases, it's worse to include a poor piece of intestine than it is to just get rid of it. And I'll touch on that on and off throughout the talk as well. Finally, as a general rule, because we're trying to put all the bowel we have back in stream, we tend to not have a lot of ostomies in our program. But there are instances when that is a better choice. It really is. I think that it's a better choice where, one, you just don't have an option because maybe there's nothing to be able to join to downstream if you've had your colon and rectum removed. Or if you think that the idea of putting continuity, restoring continuity, would actually impair your quality of life. So sometimes, having to stool 10, 12, 15, 20 times a day is an extremely impairing thing. It can mean that you can't get out of the house. You can't get more than 100 feet away from a bathroom. It's difficult to get groceries. You're having accidents in public, things that can be very, very impairing to your ability to enjoy most of what you want to do. And so I do think there's times where an ostomy is a better choice. And in children, it can be sometimes our ability to advance on feeds can be limited by how bad a diaper rash is. And so now I must say, in most children, I almost always have continuity restored. It's rare that we have ostomies in our kids, but where we're able to restore them. But there are instances where we would still make that determination. Okay. So I told you that my first big principle was if you're not going forward, then you're going backwards. Well, I'll tell you, I'm a surgeon, and here's my second major principle, which is avoid surgery whenever you can, right? So I'm a surgeon, and I'm telling you the best surgery is no surgery. So if you can do that, that's what you want. If you can be successful without having an operation, you should pick that 100 times out of 100. There would be never a reason for me to go in and try to modify someone's insides when they're already doing well. So what do we do around here? Well, we do everything we can think of. So in kids and adults on tube feeds, we would be trying all kinds of different formulas. Just because one thing isn't working doesn't mean something else might not. And we are far from prescriptive about what we do. In fact, philosophically in Nebraska, we're inclined to say that I like a quote from Bruce Lee, the martial artist, who said, "Be like water." And the idea behind be like water is don't be rigid in how you think about things. Take the situation that you're presented with and flow, adapt, go in whatever way that person allows you to go. It could be that means they need a blenderized whole food formula. It could mean that they just eat food. It could be that they have a constructed tube feed that we make with a base of an elemental feed and we're adding stuff in. It could be that we're on other specialized formulas. Change around the way you eat. We're conditioned as adults and children to eat 3 times a day, but eating 3 times a day is probably not the best thing for a short bowel patient. We need to get to eating 5 times a day, 6 times a day, grazing. No one has the time to sit down and have a 1-hour meal 6 times a day, but you might have the ability to grab crackers and peanut butter in your car. It might be like how we keep reading glasses all over the place because we lose them all the time. Well, maybe you need to have snacks all over the place. Same thing with children and bolus feeds versus drip feeds. We may want to try promotility agents. If you have a piece of bowel that's not working forwards, maybe doing something to stimulate it will be better. We might need anti-motility agents. Maybe you poop too much and we have to slow you down. And we may want antibiotics. I'm not a huge fan of being on antibiotics a lot of the time. Typically, I think when we're needing antibiotics to treat symptoms like, SIBO, bacterial overgrowth stuff, that's really a reflection of some other thing that maybe isn't right on the inside. This is just an aside and a sort of a personal hobby horse of mine. It's just when we say bacterial overgrowth, what we have to realize is that it's almost like we're personifying the bacteria and we're classifying them as good, bad, or otherwise. The bacteria are just responding to what we give them, right? So all they're doing is proliferating in response to what their environment is like, whether they're being flushed through, what kind of calories they're receiving. So it isn't that bacteria are inherently good, bad, or otherwise. They are what they are. And if we think that we're needing antibiotics to treat a patient to minimize their symptoms, at least we have to think, okay, is there some other primary problem that's leading to this, and can that be addressed? So not to say we don't use antibiotics, because we do, but I just always like to take a moment to pause and say, do we really need this? And is this the right thing? Or are we just putting a Band-Aid on a problem that we could fix? And probiotics are the flip side of that, just to say, well, maybe we need to put in good bacteria, right? And see how I say good bacteria. We don't know what's good. We don't. We think we know some things that might be beneficial, but we don't know a microbiome signature that is beneficial to a non-short bowel patient, let alone a short bowel patient. There's certain things we think might be important, but really it's mostly talking loud and waving your hands, because there really isn't a lot of good science that says one thing's better than another. Okay, so even the best of teams, the best of patients, the poor shits get stuck sometimes. So sometimes you're mired in mud, you're not going forwards, and you need to do something different. Well, that can be the time that surgery comes into play. What are some of the things that we face as teams and as surgeons? Well, sometimes we see obstruction. So there's this horrible monster on the other side, Obstruction, believe it or not, true obstruction where you're fully blocked is a relatively rare phenomenon in the intestinal failure short bowel population. Having abdominal pain and obstructive type symptoms is pretty common. Many of you who are listening to this would be like, oh, I've been hospitalized with those symptoms. But a true obstruction where you're actually blocked 100% tends to not come all that often because you're so fixed on the inside, there's not enough freedom of movement. Things can't rotate and get completely twisted. So they get partly blocked or nearly blocked. And often if we can just slow things down and modify, we can get through these episodes without surgery. But I mean, sometimes we do need to operate. Another thing that we see in children more than adults, but in adults as well, is the idea of dilation. What that is let's imagine that your bowel should be maybe the size of your thumb. And in general, that's about what it should be. But imagine it's the size of your wrist or twice your wrist. Then you start to get this piece of intestine that's so stretched out that it wants to squeeze and move food forward with normal peristalsis. But all it can do when it's squeezing is kind of squeeze at the edges and slosh stuff back and forth. You get this static, non-motile segment of intestine. That's where the bacterial overgrowth that I was referring to previously comes in, because stuff's not being flushed through. So sometimes when we're treating bacterial overgrowth, what we're really doing is band-aiding over top of a segment that's not moving forwards well. It can be hard to pick out dilation in some cases. I think it helps to have looked at a lot of it yourself, have a team that's experienced. And if you're able to, in your own institution, really try to get one radiologist who becomes your go-to person. And that's what we do here. So we have all of our studies done by one, and she's awesome. I mean, she is just so good at telling us what looks good, what looks bad, what segments are working, what segments aren't. And it makes a big difference because she can see it live, send me the images, we can go over it together, and it really helps. Here's another little aside. Darwin talked about survival of the fittest. And when we have short bowel syndrome, we often talk about adaptation to short bowel. We have many different mechanisms in our body whereby we can adapt to a shortened length. So that now we can take patients, and honestly, around here, if you guys give us a reasonable amount of colon and 40 centimeters, 30 centimeters of bowel, we're going to get most of those patients off of TPN. But with respect to the dilation issue, sometimes people talk about dilation and they say, well, oh, that's adaptive. It's adaptive dilation. But the reality is the dilation itself is not really adaptive. It's kind of maladaptive because the bowel stretching up doesn't really help anybody. So it's a change that occurred in response to short bowel, but it doesn't make you better. Adaptation kind of suggests we're doing something that helps us to be selected, that we're being selected forward. But dilation doesn't make us go forward. If anything, it stalls us or makes us go backward. Now, what we can do though with surgeons is we can seize on that. We can take that dilation and we can modify it. And that's what we'll get into in the next part of the talk. So instead of making it a giant full stop negative, we can use it to change things and maybe get back on track, maybe even better than we were previously. Okay, so what's the principle behind this? Well, often you'll hear people talk about lengthening procedures, and I'll probably use that word because I just might forget to say it. But really, when we're doing these kinds of operations, the point isn't to generate length, and I'll explain why that is. But if you look at this image of this pipe with water shooting through the pipe, that's a big wide pipe. Water's coming through it at a high force, but most of the volume inside that pipe is not touching the sides of the pipe. It's mostly in the center of the pipe. It's that column that's shooting out under pressure. And if you think about your intestines, in your small and large intestine, we absorb from what is able to touch the sides, right? So if it can touch this absorptive surface, we can absorb it. If it goes through the middle of the lumen without touching the sides, we don't have that same opportunity. So really in these operations, it's not so much that we're trying to make the bowel longer. What we're trying to do is make it narrower. We're trying to make it appropriate. So we're trying to change the volume to surface area ratio. So if we have a big dilated tube that's not functional, if I can get it down to a smaller tube and the same amount of volume goes through that tube, a higher percentage of the volume is going to touch the sides simply, right? So we can slow down the speed of that effluent, we can absorb better, and that's going to give us the sort of the benefit from the procedure. Now, it's often easier to explain to a patient or to a parent the idea of lengthening as opposed to a volume to surface area ratio change. But so when you hear about lengthening procedures, sometimes patients will come to me, parents will come with a child and they'll say, do you think that her bowel will get more dilated so we can do a lengthening procedure? And I say, well, it might, but that's not necessarily a desirable thing. It's more like something we have to do if that occurs. But honestly, you give me 12 centimeters or 15 centimeters of non-dilated bowel in a child, and I'll take that over 25 centimeters of dilated bowel because the non-dilated stuff tends to work better. Okay, so let's get into some operations, and I'm not going to go through the history of the whole field. And I'm not even going to touch on one major operation, which is the Bianchi procedure. I'm happy to address it in questions later, but I just thought, I have a half an hour and I'm not going to dwell on that too much because it's not done all that commonly anymore. And this is something you're much more likely to come across. This is called a step procedure, a serial, so one after the other, transverse, typically meaning side to side, enteroplasty. Entero means intestine, plasty means change. So a step procedure. First was designed by H.B. Kim in Boston. That's a really nice paper and a series of papers. In this picture, they sort of show you're doing these staple firings back and forth across the bowel. Now, in this original paper, he shows the staple firings being done side to side. For technical reasons, that's not how I do them. And I've done a lot of these, and I'll get into that experience. I think there's maybe benefits doing it the way that I do it, but either is fine. That's more the art of medicine than the science of medicine. Now, I hope this projects. This is a video. You may or may not hear the sound. The sound is irrelevant because I'll talk over it. But this is a procedure. This was a girl who had a midgut volvulus when she was 6 years old. When I did this operation, she was about, she was probably 11. Maybe she was 10 or 11 at the time. Interestingly enough, this is getting kind of old. So this is bowel that's pretty dilated. That's up to 8 centimeters. It should probably be 2 to 3. What I'm doing intraoperatively here is I'm taking a Foley catheter, passing it through her intestine, suctioning out the contents, looking for narrowings on the inside. I'm looking for strictures, making sure there's no blockages on the inside that I can't see. Once I've got it all laid out, now I take this stapler. What this does is it fires 3 rows of staples, 3 rows of staples. And these are teeny little 1 millimeter staples. And then it cuts with a knife between them. And so you'll see, I position it on the bowel and I go, squeeze this trigger, the little knife blade goes down, splits the tissue. And as I lift that away, you'll see how it falls apart like a V. And so that's sealed on each side, 3 rows of staples and 3 rows of staples. Now I make a little hole on the opposite side, not in the intestine, but in what's called the mesentery that feeds up to the bowel. Make a little hole, take the stapler and put it in the opposite direction and do the mesenteric side step. So same thing, fire it, and it's going to split the tissue and open up into a V. And then I fast forward here in the video to when I'm at the end of this procedure. And you'll get a sense of what the bowel looks like when it's all done. So when it's all done, you've taken this big dilated tube and you've done all of these firings and you've created this zigzag tube that's now a normal size. You can see it's about the size of my thumb. And it's peristalsing, which is why it looks skinnier and some. There's me pointing to it. because now it's got good peristalsis that can move food forward. And that will dilate up just a teeny little bit. And in the end, you take this bowel that can't move forward and you can turn it into a much more narrow tube that moves forward properly and absorbs much better. Now, interestingly, this girl, she's awesome. She's now 18 years old. And she came to us on 100% TPN. And now she's completely off TPN. She's just, beautiful and just looks so grown up. I actually passed her in the hall. She was coming into clinic a couple of months ago and she was done up. And it's like when you see your daughter and she goes to prom and you're just like, oh my God, who are you? Like, when did I go from having a little girl to having a young woman? And that's exactly how she looks. I wouldn't have recognized her because she looked like a Hollywood starlet. But so that's a step procedure. And that's stepping a fairly long segment of bowel in this girl. So I wrote a paper about this along with my team. And so this was our initial experience. It's a pretty big experience looking at serial transverse enteroplasties in kids. What did we learn when we looked at them? Well, so in this case, I think we had 51 steps when I did this paper. We're up to more like about 150 at this point. So probably someday I should update this, but what are the salient points from the paper? Well, in this roughly 50 kids that we did it on, the average age was about 1 year old. Now, I'm not a real big fan of step procedures being done prior to the age of 1. I think that's a time when the body is still growing, the bowel is still adapting. And if you get in there and you do stuff too early, I think you can't do as good a job as you want to. I think that the bowel hasn't decided what it's thinking about doing yet. And so you intervene, but you end up intervening again and again. And I think you're better off to try to not do it. So have I done them in the first year of life? On occasion, yes, but I don't like that. I would rather manage a child expectantly and give them some time to grow and see how the bowel works and try some different things before jumping right in. So I'm not a big proponent of the idea of stepping right at birth or very shortly after birth. There are other people who believe that, and we're all free to believe what we want. I just think my own experience doesn't bear out that that's the path to success. What length gain do we get? Remember, I told you it's not about length, but yet at the same time, length is a little bit of a way that we can describe how we modify the intestine. Well, in general, you get about a 50% gain in length in this population of patients. So the bowel needs to be dilated up to about 3.5 to 4 centimeters in diameter before you can start to modify it. The more dilated the bowel is, the sort of quotes greater the length gain because you have to intervene more, you have to change it more. So if you get bowel that's 6 or 7 or 8 centimeters dilated, like what we saw in the movie, you can get 100% increase in length because you're doing considerably more modification than if you take bowel that's 3.5 or 4 centimeters. It goes fairly smoothly. It takes about a couple of hours to do. The median blood loss is 0. It's not a very bloody operation. You can do it with just essentially no bleeding at all. It takes about a week or so for the bowel to wake up and get moving. So we usually get all fully clamped, get our G-tube clamped or whatever, and get on feeds in about 8 days. And your average kid's out of the hospital in about 2 weeks. Can you do step procedures in adults? Yeah, sure you can. It doesn't happen as often because the bowel tends to not dilate in adults to the same extent that it does in children. But absolutely, you can do it in adults, and I've done it in a number of adults, and it's just as efficacious. So if you have a dilated segment in an adult that is not working forwards, it will be amenable to a step procedure. All right. Boom. So what? So I show you guys, hey, we can do this operation and we can do all this fancy stuff. What's the point? Well, in this paper, these two figures are showing you something called Z-scores. Z-scores are how many standard deviations someone is away from normal. So basically, these are like growth curves. Children, we're always looking at the curve that they grow, and we want them to track along a growth curve. So they can be at the 50th percentile, they can be at the first percentile, or anywhere in between, or below the curves. The point of this figure is this is looking at weight and height. And it's showing that from 6 months prior to doing a step procedure until 12 months after a step procedure, if you look at that, you see those kind of look roughly like straight lines. And the point of that is to say, these children grew along a growth curve over that 18-month period, from 6 months before the operation to 12 months after. That's all you're trying to show here. You have to accept they were growing just fine, tracking on their growth curve. Here's where the important thing is, though. We look at enteral calories that we gave them. So how much could we give them into their gut, and how much parenteral or TPN did we have to give in order for them to grow? So remember, every kid grows through this whole 18 months. Now, enteral calories delivered. Well, we can fake calories a little bit, can't we? Because we can say, I could give you short bowel syndrome and I could have you eat 4,000 calories a day. But if you poop out 3,500 calories, I may not be doing you a service. So I can say, oh yeah, we're giving 4,000 calories a day. But unless I'm really measuring what comes out the bottom end, I'm not sure what that means. But I'll tell you what I do know what means 100% is parenteral calories. Every calorie I give you intravenously, I know you're getting that calorie. So if I can prove to you in that last slide that all these children grew, and then I can show you that I can get them to grow with less and less and less TPN, the only conclusion you can make from that data is they must be absorbing better, right? Because they don't need as much intravenous support, they must be absorbing better. And that's what the data shows. The data shows, if you look at this population, by the time they are 12 months after a step procedure, that little bar that's in the center of the gray box is a median. So the median child is on like 10 calories per kilogram per day of TPN. That's where most of those kids are on parenteral nutrition 2 days a week or 3 days a week, and they're en route to coming off of parenteral nutrition. So really what you're seeing is a population where a month or a year after the step, a high percentage of kids are off TPN or coming off of TPN already. Now, one of the things they asked me to talk about is, well, what about doing this procedure again? You know, there are people who say you shouldn't do this operation. And I'm going to touch on this in a little bit. They say, oh no, there's no reason to do a step procedure. You don't need to, just keep them on TPN. I philosophically don't believe that. I believe we should be working to get off TPN, and I told you that. And I think we have the data that bears out that this works. There's probably some reasons why. But there's also people, even people that do the operation, who say, well, we don't think you should do it a second time if you have, you know. And I would argue back again, well, if you're stuck and you're not coming off of TPN and you see dilation and you've done all the other things we've talked about up to this point to make surgery in the risk-benefit category a favorable decision, then I don't see why you wouldn't consider doing something to try to help as many people as you can. So what we did now is we looked at our redo steps. So I just posted up the primary steps. So in this paper where we looked at people we did, or kids that we did second operations on, and there's about 30 of them. I forgot to write that down. There was 30 in this paper. So what did we see in this population? Well, now they're a little older, you know, so the median child is about 2 years old, a little bit over. I would say many of these ones that have second steps are kids that had their first step done somewhere before they got to us, and they had it done early in life. And that's partly why I tried to make the argument to you to say, I'm not a big fan of the early steps, because I think it tends to make you have to do more stuff later. Whereas if you can wait, you can get away with one operation. The operation's about the same, maybe takes a teeny bit longer because it's a little more stuck. There's not really much bleeding. You can still do it pretty safely. Still takes about a week or so for the bowels to get going, and a couple of weeks till you get out of the hospital. So the bottom line is we can do the procedure in a safe fashion. And here you see, oh, I just made a little point to show the length gain that you get is not as great as what you get on the first one. It's because what we're trying to do here is create uniformity. We're trying to get the bowel to be uniform in shape and size all the way throughout. So we're not interested in making it quotes longer as we are just getting it down into a better shape. And the long story short from all of this data is when you look at this figure, it's a lower population of patients, so the bars get a little bigger. But the bottom line is, if you look out over time, same sort of format, you look at from 24 weeks prior to a second step, falling out to 12 weeks, and then 24 weeks, and then ultimately out to the most recent, which in this case is a number of years out. As we get years out from these, the median child is off of TPN again. So there are some kids who don't come off of TPN. It's just the way it is. We don't seem to be able to predict who is going to be able to be successful. And so if we don't know up front who's going to be able to be successful, then the challenge it poses to us is, does that mean we do nobody? Because we might be wrong in a few cases. We might do an operation and it gets you down on TPN but not off of TPN. Does that mean we don't do it on anyone? Well, I don't buy that, because if I can show you that with one step procedure, 70% of the patients come off of TPN, and of the 30% that are left, another half of that 30% comes off of TPN. Now I've got 85% of those patients coming off. Whereas the data would show none of those patients, if they just stay with dilated bowel and they stay on 80% TPN, they're not coming off TPN. There's nowhere to go forward. All they do is TPN maintain. If you believe in just maintaining people on TPN, well, more power to you. I guess that's what you believe philosophically. It just isn't what I think. Here's one last operation, and then I will wrap up reasonably close on time. As I've done more and more of this stuff over the years, I've come to realize that in some cases because we're getting so much better at getting people off of TPN with shorter lengths of intestine, sometimes even a step procedure isn't necessarily the best way I want to go if I'm changing the bowel. Sometimes if what I'm trying to do is get the bowel to be more narrow, I can do it not by making the zigzag step pattern, but by doing something called the longitudinal excisional tapering enteroplasty, LETE. It's to take a big tube and make it into a more narrow tube. This is also something, honestly, that can be effective in patients that have dilation where they're given the diagnosis of pseudo-obstruction. You know, in most cases of pseudo-obstruction, we don't really know what the underlying cause is. We're just left with a pattern of dilated bowel that's poorly functional. And there's things we can do to actually improve that function. So here what we do is, instead of firing staplers back and forth across the intestine, we're firing them parallel to the long axis of the intestine and kind of taking off that excess bowel. And so when you see this finished version here, this was a patient that had this great big dilated bowel that was sort of 6 feet long. And so we excised this curtain of excessive bowel, reducing what's left to a much more normal size. And this patient then goes on to fly. So instead of this big, distended, gassy belly, always on antibiotics, poor tolerance of food, vomiting every second day once they're filled up enough that they can actually puke, or having great big high volume poops, we lower them down to a more appropriate luminal diameter, and suddenly we restore function. Distension's gone, ability to tolerate meals is returned, stool pattern reverts back towards normal. They start to see form in their stools. So we don't always have to keep every bit of absorptive surface. In this patient, you can see all that bowel in the middle. That's plenty of bowel. So if we get rid of this excess that isn't helping us, we actually do a better thing for that patient, even though we've technically reduced absorptive surface. So as we wrap up, what are my summary points? Well, I guess I believe philosophically, if you're not going forward, you're going backwards. So I think we should be, every time we see you in clinic, we should be doing something that either helps to get you off of TPN or makes your life better in some way. So if we've decided this is the best we can do on reducing TPN, then we should be saying, how do we make life better? How do we get one less bowel movement? How do we get 5 hours of uninterrupted sleep? How do we get 2 more hours off of a TPN? There always seems to be something that we're working towards. I think if we do that, then we always have a common goal and a common purpose, and we do the best possible things that we can for you. I really believe patients should be transferred early to specialized centers. Obviously, you could say I got a vested interest in this, but I just think this is the right thing. I think this is where the field is being driven forwards. I think we have concentrated experience in the challenging, the more obscure diagnoses. If, for many patients, you may be the only person that your treating physician has ever seen with short bowel syndrome. And so while that can give you a very engaged caregiver, and we want to keep those engaged people involved in your care, you probably also want to be somewhere where every week they're doing a clinic and there's 20 patients with short bowel coming in, right? So if we see 20 adults on a Tuesday and we see 20 kids on a Wednesday, it's kind of nice to be at a place where, gee, everybody understands the language you're talking about home pumps and G-tubes and central lines and TPN prescriptions and lipids and all the different things that you're being forced to learn about as a patient or as a clinician. I believe in restoring continuity early. I think we should avoid surgeries when possible, but when you need them, I think that you should do the best thing you can to help that patient to be able to progress forward on their feeds and come off of TPN. So I don't think you should hesitate. Now, all of these different kinds of surgical techniques work, but here's some things that I think are important. One of the problems with these operations is they're conceptually easy to do. So certain operations we do in surgery are hard. And so when an operation is really, really hard to do, because it's technically hard and there's lots of little things to sew together, not everyone wants to do those things. They go, man, that's really difficult and I probably shouldn't do that. I should send that person to a specialized center. The problem with these operations is everybody figures they can staple. And so then they go, well, I looked up the paper and I see what they do. I'm just going to try one of these steps. Or, gee, I saw one during my training. And, let's try a step procedure. I heard they work. The problem is the devil is in the details, both in the decision process, but also in how you do the operation. And so I guess I would contend to you that honestly, it doesn't look like difficult, but most people shouldn't do this. Because if you're only doing this once in your career, or once every couple of years, or even once or twice a year, I'm not so sure this is something that you should be doing. I think you should either send it to someplace where they're doing more, or you should become that person who's getting them sent to you from all of your colleagues. You know, and my next point here, knowing when to operate is the most important thing. It's not, can you fire a stapler back and forth across the bowel? Because yeah, you can. But how you do that and when you do it is the critical thing. If you do it the right way in the right circumstances, you get the results that we publish. If you don't get those results and you see a different outcome. Then you say, well, gee, this procedure doesn't work. And I just don't believe that to be the case, because I think our patients are living proof that it works. My final point is, you don't want in your program to have a large group of interested surgeons, because, you know, it's like, you know, the old saying, what's the best way to starve a horse is ask two people to feed it. Like, nobody learns, nobody becomes an expert, nobody takes responsibility. You don't want a whole bunch of people interested. You want one person, maybe two people that are interested, and you want to concentrate the experience with them so that they can develop it, so they can make mistakes and learn from it, so that they can do better and better and better and get that decision process honed and figure out the technical details of the operation. That's what I think is important. So that's the end of my talk, everyone. I will be more than happy. I'll be back for the panel discussion at the end, and I'll be back at the next panel after that. And I'll be happy to address any questions that you have. I tried to go through a bunch of stuff pretty quickly, and some of it may require me to flesh it out a little bit for you. And it could also be in conflict with what you believe or what you've heard. And I'm open to that. You know, I'm happy to hear other people's opinions on things. So thank you very much.